Your clinical team is doing excellent work. Patients are coming in, and services are being delivered. But somewhere between the exam room and the final insurance check, a significant portion of that earned revenue is quietly disappearing. This is revenue leakage. It rarely shows up as one massive loss. Instead, it bleeds out slowly through denied claims, uncaptured charges, and minor documentation gaps that compound over the calendar year. Recent data analyzing over 375,000 practice-based physicians shows this problem is accelerating. Between 2024 and 2025, net revenue leakage from these exact issues increased by 25%. In 2024, providers lost $38.6 billion to uncollected services. By 2025, that jumped to $48.4 billion. Shrinking this total volume, overlaying lines represent a mid-sized practice. The median denial rate climbed to 2.7%, and bad debt rose to 1.3%. These fraction of a percent shifts equal hundreds of thousands of dollars for a busy clinic. In fact, 60% of medical group leaders reported this exact upward trend in their claim denials last year. Persistent revenue leakage acts as a systemic drain on practice margins, demanding a structural shift in administrative workflows to protect the bottom line. To understand why the system is leaking, we have to look upstream at how charges are captured at the point of care, and specifically at the prior authorization process. The average U.S. physician and their immediate staff now spend roughly 13 hours every single week navigating prior authorization requests. That is nearly a day and a half of clinical capacity lost, directly delaying patient care and driving physician burnout across the industry. When those claims eventually reach the billing department, the friction continues. Industry data shows that 86% of claim denials are entirely avoidable, yet practices consistently fail to correct them. This chart tracks the life cycle of denied claims. While 86% of these claims are technically avoidable, between 50 and 65% of them never reach a resolution. They are simply abandoned. The math explains the abandonment. The average cost to rework a single denied claim is about $25 in administrative time. For an overworked team, letting it go is simply the path of least resistance. This is the bandwidth trap. Practice staff handle appointment scheduling, phone volume, and immediate patient collections, pushing revenue integrity to the bottom of the priority list. Assigning generalist staff to fight highly complex, constantly shifting payer algorithms virtually guarantees a high error rate and abandoned revenue. Stopping this bleed requires specialized expertise. You need AAPC or AIMA-credentialed professionals who meticulously track annual CPT code updates and specific payer guidelines. Hiring that level of expertise in-house is expensive. The average base salary for a credentialed revenue integrity specialist currently sits above $82,000. When you factor in benefits, payroll taxes, office overhead, and continuous training, the fully loaded internal cost pushes much higher. Then there is the hidden operational tax. Healthcare administrative roles suffer from high turnover, forcing practices into a continuous loop of recruiting, training, losing the employee, and starting over. The alternative strategy gaining traction among smart practice owners is outsourcing the revenue integrity function to a dedicated credentialed team, like Staffingly. Each practice is assigned a dedicated team of credentialed specialists who operate directly inside the existing EMR on a daily basis. This side-by-side comparison matrix shows the stark financial difference. On the left, we have the towering, fragmented stack of the fully loaded in-house hire, exceeding $80,000 with a high turnover risk. On the right, the solid block represents Staffingly's flat rate of $399 per week, roughly $20,700 annually, with zero turnover risk. Watch as that towering in-house column shatters into its individual costs. Staffingly eliminates the training overhead, the benefits packages, and the productivity losses from staff departures, leaving you with a single predictable line item. Managing this highly technical work internally forces a practice to absorb constant labor market volatility and massive financial risk, often just to maintain physical oversight of the employee. Top-performing healthcare organizations carry a final denial rate of just 1.6%. They achieve this through strict, dedicated processes, not luck. By outsourcing, practices bypass months of recruiting. A dedicated team can go live in 14 days, connecting directly to major platforms like Epic, Athena, or eClinicalWorks. These outsourced teams also utilize specialized artificial intelligence to augment the daily workflow and handle the sheer volume of claims. The AI handles smart routing, automatically prioritizing the claims queue based on financial value, the likelihood of a denial, and strict payer timing deadlines. Automated quality audits act as a pre-submission shield, catching CPT mismatches, modifier errors, and specific payer rule violations before the claim ever leaves your practice. Broad adoption of AI in healthcare is projected to reduce workloads by up to 30%, saving billions of dollars in wasted effort. But the technology does not replace the human expert. The AI handles the repetitive sorting and data validation, leaving the credential specialist free to apply nuanced clinical coding judgment to the complex cases. This process provides total management transparency. Practice administrators receive weekly KPI dashboards tracking first-pass resolution, turnaround times, and accuracy, completely replacing opaque ticket queues. Integrating an AI-augmented outsource team upgrades your entire billing infrastructure, shifting your practice from reacting to denials to proactively predicting and preventing them. The core operational shift is clear. Practices must stop assigning complex revenue integrity tasks to general administrative staff and start treating it as a highly specialized, dedicated function. This transition does not compromise security. Outsourced workflows operate under strict HIPAA and SOC 2 Type 2 compliance, complete with fully executed business associate agreements. This structural pivot is essential for mid-size practice owners and billing managers who are fighting creeping accounts receivable days, struggling with bandwidth strain, and unable to justify an $80,000 internal hire. Massive healthcare systems with fully funded compliance departments and zero billing backlogs simply do not need this service. This effort versus impact quadrant chart maps the strategic decision. Relying on general staff to append modifiers lands squarely in the high practice effort, low impact quadrant. Deploying credentialed outsourced staff equipped with predictive AI lands in the low practice effort, high impact quadrant. Making this transition requires an initial 14-day commitment. During a risk-free pilot, your practice trains the outsourced team on your specific clinical protocols and workflows. There is no long-term vendor lock-in. Operating on month-to-month terms guarantees that the outsourced team has to continually prove their financial return on investment to keep your business. Curing the silent bleed of practice revenue requires permanently abandoning the frustrating cycle of hiring and retraining. Deploying a dedicated, tech-enabled team is the clearest path to defending your bottom line.